Let me to continue the series of renal transplantation update. I'm going to discuss today diabetes and renal transplantation. It is very difficult to cover all issues related to diabetes and transplantation, but today I'm going to focus on why the presence of diabetes as an original kidney disease is an important issue affecting transplant outcome, and as well as the development of diabetes after transplantation in what's known post-transplant diabetes, why these points, either diabetes de novo or post-transplant, are important and affecting transplant outcome. Then what is the definition of post-transplant diabetes, and what are the most important risk factors for development of post-transplant diabetes, and the approach for management, including prediction, because we cannot prevent what we cannot predict, and the major lines of treatment are lifestyle and drugs, and at the end the management will be presented at a glance. Let us start with the issue of diabetes. All of us agree about that diabetes is one of the important causes of end-stage kidney disease. According to the last report of United States Renal Data System, diabetes is the leading cause of end-stage kidney disease. However, the majority of renal replacement therapy for diabetic patients is not transplantation. Transplantation only for 17% of diabetic patients, and the majority of patients are replaced by hemodialysis. So this is a point deserves consideration and to be studied well. And I think this article tried to answer this point. This is the beauty of the presence of data registry. So just one click, you can know the original kidney disease for 700,000 patients, IgA 11,000, FGS 30,000, 6,000 membranous nephropathy, 2,000 MPGN, lupus 16,000, vasculitis 5,000, diabetes 617,000, and approximate 30,000 polycystic kidney disease. So these are the major causes of the original kidney disease. Not only numbers and the percentage of original kidney disease, but also the outcome, the fate. The data shows the follow-up. As you see here, the evolution of the case and the outcome is summarized under 3 color codes. Red or brown, this means death. Yellow color means transplantation from living donor, and the other color is transplantation from deceased donor. If you look to the diabetic patients, the majority of patients died on hemodialysis. So this is a bad news. So it seemed that either the patient died before transplantation, or there is discrimination against diabetes for transplantation. And this is not in the United States, but also not only in the United States, but also in other countries like Finnish registry for kidney disease. Here, the probability of kidney transplantation is low in type 2 diabetes, although the outcome is not so bad in type 2 diabetic patients. Regarding the solid outcome criteria of transplantation based on diagnosis of diabetes, if the patient is diabetic, the hazards of mortality increased to fourfold in univariate and multivariate analysis. So the patient died significantly higher if the patient is diabetic, but the graft is not affected significantly by diabetes. And this is a very funny data. This is the clinical consequences of diabetes mellitus in patients after kidney transplantation in a paired kidney analysis. What's meant by paired kidney analysis? Here, the kidney comes from cadaveric donor. One kidney goes to a diabetic patient or patients who develop post-transplant diabetes, and the other kidney goes to non-diabetic patient. So the source is the same donor, but the outcome is different. Here, the 5-year patient survival is affected because of diabetes. So it seems that diabetes reduces 5-year patient survival by 15%, from 96 to 81% 5-year patient survival. However, graft survival is not significantly affected by diabetes. Again, This slide summarizes the post-transplant cardiovascular risk factors. You can see clearly that diabetes, including post-transplant diabetes, is a significant risk factor for cardiovascular disease. And the evidence is very strong toward the link of diabetes with the risk factor of cardiovascular disease after kidney transplantation. Regarding post-transplant diabetes, is it very important, crucial, and affects patient outcome? This is one of the very new articles in children. So incidence of new onset diabetes mellitus and association with mortality in childhood solid organ transplant recipient, a population-based study. You can see here clearly that transplantation is associated with increased probability of diagnosis of diabetes. So in comparison to non-transplant patients. And diabetes increases significantly with the transplantation of lung and multiple organ in comparison to kidney, heart, and liver transplantation alone. And development of diabetes after transplantation is associated with increased mortality of recipients. So again, like the presence of diabetes from the early beginning as an original kidney disease, or here, development of post-transplant diabetes, mortality of the patients increased significantly. And this is one of our articles showing that the incidence of post-transplant diabetes is 22%, and the diagnosis of diabetes in comparison to control patients without post-transplant diabetes, you can find here significant increase in hypertension, post-transplant, hypercholesterolemia, ischemic heart disease, proteinuria. This means that both retinopathy and other complications, so development of post-transplant diabetes is associated with increased macro and microvascular complication. I'd like to end this sector by this slide, and this is the guidelines of living kidney donor transplantation that was released from British on March this year. Type 1 and type 2 diabetes are not contraindication to living donor transplantation, irrespective of whether they are underlying cause of renal failure. Both the donor and the recipient should be counseled regarding the increased risk associated with this surgery. And one of the risks is recurrence. We shouldn't respect recurrence so much because it takes a long time for its appearance, and it takes another long time for affecting graft importantly. So the second sector is the definition, diagnosis, and risk factors of post-transplant diabetes. This is the American Diabetes Association 2018 diagnostic criteria for diabetes and pre-diabetes. Here you can find fasting plasma glucose equal or above 126, 2-hour plasma glucose exceeding 200, A1C above 6.5%. Or pre-diabetes if there is impaired fasting plasma glucose between 100 to 125, 2-hour plasma glucose in the 75-gram oral glucose tolerance between 140 to 200, less than 200 milligram per deciliter, or A1C between 5.7 to 6.4%. So we can use this definition to diagnose post-transplant diabetes. However, using A1C shouldn't be used alone to screen for diagnosis of post-transplant diabetes within the first year, because it will underestimate the condition. And I personally recommend against its use altogether within the first 3 months because of the variability of hemoglobin. And this is regarding the recommendations. Oral glucose tolerance test is the preferred test to make a diagnosis of post-transplant diabetes mellitus according to the American Diabetes Association guidelines. Regarding variability, I hate variability in any parameters in medicine. And here, this is the very nice, smart study, shows variability of glycemic state after continuous plasma glucose monitoring during at the time of transplantation, after 3 months and 6 months. What do you see? Variability is always there, and hyperglycemia is more manifest afternoon and during the night. And here, variability is more common And nocturnal hyperglycemia is more manifest, especially if the patient has prior transplant diabetes or develop post-transplant diabetes, new onset diabetes after transplantation. All these points should be put in mind in the treating patients with hyperglycemia, is to be sure that we control the plasma glucose all through the 24 hours. This is a very important, crucial statement. If we have hyperglycemia within the first 6 weeks after transplantation, we should consider this as transient hyperglycemia. If it continues beyond 6 weeks or diagnosed after 6 weeks, we can say post-transplant diabetes mellitus. In the first period after transplantation, we depend upon plasma glucose. After that, we can depend on this triad, putting in mind that A1C alone within the first year will underestimate post-transplant diabetes and need help from other laboratory tests. What are the risk factors? In one slide, risk factors for development of post-transplant diabetes are either pre-existing diabetic risk, including increasing age above 40, increasing body mass index above 25, certain race, certain genetics, pre-diabetic state, and this is why I'm very interested in the pre-diabetes, because it is a window for prevention of diabetes, metabolic syndrome, especially low HDL. So the message is, please go ahead to control modifiable risk factors, and we should be more aggressive for these risk factors, especially if in patients with non-modifiable risk factors. After transplantation, we use immunosuppressive drugs, and the most important immunosuppressants associated with diabetes are corticosteroids, calcium inhibitors, and mTOR inhibitors. Inflammation, hepatitis C, CMV, HLA mismatch, rejection, all these inflammatory environments are associated with increasing risk of diabetes. Other risk factors like polycystic kidney disease because of insulin resistance, or in minority of patients have cysts within the pancreas, statins, hypovitaminosis D, hypomagnesemia. Even if statins increase a little bit the risk of diabetes, if we should use them, especially if there is hypercholesterolemia, because this will improve the cardiovascular status and reduce mortality. In our experience, the risk factors for post-transplant diabetes included age, post-family history of diabetes, and high body mass index and HCV infection. As you see here clearly, the hepatitis C positive patients are in higher risk for development of post-transplant diabetes. In liver transplants, a lot of risk factors, either classic risk factors, like pre-liver transplant fasting glycemia, high body mass index, family history of type 2 diabetes, or certain race, or donor-dependent factors like liver steatosis, deceased donor, age above 60, impaired liver function, or the procedure-dependent factors like acute graft rejection, no induction therapy, or cold ischemia above 9 hours, liver transplant specific factor like HCV, CMV infection, or the use of immune suppressant drugs, emerging risk factors like long stay in the ICU, low plasma hypomagnesemia, excess body fat, statin therapy. So all these are the risk factors for post-liver transplant diabetes mellitus. Regarding immune suppressive drugs, calcineurin inhibitor, especially tacrolimus, are associated with the diabetes, and the mechanisms are either reducing insulin secretion or increasing insulin resistance. And the corticosteroids increase insulin resistance, increase hepatic glucose production, reduces pancreas insulin secretion, or adipose tissue lipolysis increase. And this is one of the experimental studies showing that tacrolimus is associated with reduction of the beta cell mass, and that was ameliorated in the experiment by using empagliflozin. This means that tacrolimus may lead to diabetes through exaggeration of sodium glucose cotransporter expression. That is ameliorated by the empagliflozin, and the mechanism of tacrolimus-induced diabetes is in enhancing as well the caspasis or apoptosis is increased. mTOR inhibitors affect either the central through affecting the islet cell, beta cell. Through affection of beta cell, it will mTOR inhibitors reduce insulin secretion, or it acts, or mTOR inhibitors act peripherally through inducing insulin resistance and manipulating the glucose, the uptake by the tissues. So this is the mechanisms of the diabetogenic potentials of mTOR inhibitors. If you want to go and review a lot of risk factors for post-transplant diabetes, please go ahead and review this video that I recorded on February 5th this year. How to manage post-transplant diabetes regarding prediction and lifestyle modification. This is the pre-transplant hemoglobin A1C. If it is high in the pre-diabetes range, please be more careful, because these patients may be more risky for development of diabetes. As you see, you see here, pre-diabetes has been identified as a risk factor for post-transplant diabetes throughout long-term follow-up, and offers a window of opportunity for intervention and for prevention of development of diabetes. This is why I am so interested by diagnosing pre-diabetes. This is the from Saudi journal. The management of post-transplant diabetes is through the same traditional ways of management: diet, lifestyles, and using drugs, oral, or insulin, or combination of them. Regarding diet, we should avoid obesity and metabolic syndrome in transplantation, and this will improve the glycemic state. And here this article stresses upon the role of dietary fructose in causing obesity and metabolic syndrome. It seems that Mediterranean style of diet is associated with low risk of new onset diabetes and after transplantation. And through the days, through months, through reading, I am quite convinced by the Mediterranean diet, which Mediterranean diet is rich in fruits and vegetables with less amount of red meat. Regarding exercise, we should advocate exercise because this is a lifestyle modification. So diet, exercise, stopping smoking, all these are very beneficial for management of diabetes. Regarding drugs, up to this moment, we don't have the strong evidence how to treat the patients. As you see from this Cochrane reviewer group that included 7 studies, which together includes 300 patients, the glucose lowering agents for treating pre-existing and new onset diabetes after transplantation, it seems that the evidence is not so strong. But one of the key messages is early use of insulin, especially basal insulin. Here, in this small study, randomized control study, using of the basal insulin from early days after transplantation reduces the diabetes up to vanishing of diabetes at the end. This is a very important beneficial effect of basal insulin on islet cells. So early use of insulin, especially if we diagnose diabetes from early days after transplantation, may make a big difference as shown here, and I think we are waiting further studies to prove this concept. This is another study, continuous subcutaneous insulin injection therapy following the presented algorithm is easily feasible and safe in patients with hyperglycemia immediately after kidney transplantation, clearly improving glycemia over the first week of therapy, even when compared to basal insulin isofan treatment. However, continuous subcutaneous insulin injection therapy can help prevent the development of post-transplant diabetes awaits completion of the ongoing SABT NODAT trial follow-up. So this is another study showing another data showing the concept of using insulin to prevent diabetes. Regarding drugs, I think the choice of drug, we have the traditional groups of drugs that can be used for treating hyperglycemia, anti-hyperglycemic drugs. And I think the factors that guide us in selecting the specific drug are kidney function of the graft. Secondly, drug-drug interactions with anti-diabetic drug with immune suppressive drugs. And thirdly, the characteristics and demographic of the patient. So, for example, for metformin, I'm not going to explain the mechanisms, the disadvantages and disadvantages, but here the evidence in post-transplant diabetes, neutral effect on patients or graft survival, efficacy in post-transplant diabetes not demonstrated. However, we can use metformin, suppose that estimated GFR is within the therapeutic window, about 30 milli per minute, because below 30 milli per minute, we cannot advise for metformin use. But there is no drug-drug interaction with immune suppressive drugs with metformin. Regarding sulfonylurea, you can read here the disadvantages, hypoglycemia and weight gain, and the advantage, rapid onset of action and low cost. Here, sulfonylurea not effective. This drug and ribaglinide effective in improving glucose control. So this sulfonylurea and glinides. Here, ribaglinide is not sulfonylurea, it is non-sulfonylurea insulin secretagogue. But look here, glipniclamide, cyclosporin increased glipniclamide, and cyclosporin increased ribaglinide. So this is why it's better to avoid combining ribaglinide with cyclosporin. And if there is any renal impairment, it's better to avoid the glipniclamide, because it is of long action and has active metabolites. TZDs, no known drug-drug interaction. DPP-4 inhibitors, sitagliptin, cyclosporin, increased cyclosporin trough level. Vildagliptin, tacrolimus is reduced. Insulin, no known interaction with immune suppressive drugs. GLP-1 receptor agonist, no known drug interactions. Sodium glucose cotransporter 2 inhibitors. Canagliflozin, cyclosporin increased canagliflozin level, to put in mind. And this is the issue of ribaglinide, which is non-sulfonylurea insulin secretagogue. Here there is interaction with cyclosporin, so don't use ribaglinide with cyclosporin. And this is the summary of important drug-drug interaction prepared by the Clinical Pharmacy Department of Urology and Nephrology Center. Here, ribaglinide and cyclosporin, the risk is for hypoglycemia because cyclosporin increases ribaglinide level. Cyclosporin and the MMF with rosiglitazone, it may increase the mycophenolic acid area under curve, so we should be cautious in monitoring the patients with MMF. Sitagliptin increases cyclosporin toxicity, and glipizide and glyburide the same, increasing cyclosporin toxicity. So it's better to put these points in our mind while we are selecting drugs. The second axis, can we change immune suppression to reduce the risk of diabetes or to manage diabetes? This is one of the studies, this randomized study of conversion from tacrolimus to cyclosporin, and this study included 40 patients in each arm. So here the patients are kept on tacrolimus and here are converted to cyclosporin, and the result of this study was beneficial. Conversion to cyclosporin was associated with improvement of glycemic state. And this is another study, randomized control trials, assessing the impact of tacrolimus versus cyclosporin on the incidence of post-transplant diabetes. If we look here, we have 3 groups of patients, 3 lines of treatment, and the patients were followed after 3 months and 12 months. Here we have tacrolimus and steroid withdrawal, tacrolimus with steroid minimization. With steroid withdrawal, as we do in our center, we stop steroid within after a week of transplantation in the majority of cases of low immunological risk, using tacrolimus and mycophenolic acid. And this minimization is to continue on a small dose of steroid, and this is cyclosporin and steroid minimization, because I don't agree about cyclosporin and steroid withdrawal. So what do you see? Euglycemia is represented by dark color. So cyclosporin plus steroid minimization is associated with high significant euglycemia in comparison to tacrolimus. Look here, rejection is significantly higher with cyclosporin arm. So it seems that it's more wise to use tacrolimus with steroid minimization or steroid withdrawal according to the immunological risk of the patients to gain the importance. So the lesson that we here in the center, we learn through the time is to use the drugs in a wise way, avoiding using targeting a very high level of tacrolimus unnecessary, and the cumulative dose of steroids that we accustomed to use high doses of steroid. Nowadays, we taper the steroid either toward steroid withdrawal within a week of transplantation, or using steroid in relatively moderate immunological risk, but with a small dose. This is our experience in steroid withdrawal regimens, that it reduced post-transplant diabetes significantly from 15% to 5%, and without affecting graft or patient survival. Regarding the management at a glance, again, to diagnose, we should monitor glycemic state. A1C is not enough for diagnosis of post-transplant diabetes within the first year. And if hyperglycemia is early, in the early 6 weeks, we should consider it as transient hyperglycemia and diabetes if it persists. The treatment, if we are here in the first week, it's better to start insulin. And starting insulin may protect the islet cell, especially the basal insulin. And then later on, we treat the diabetes as type 2 diabetes, lifestyle modification using anti-diabetic drugs. And this is one of the beloved presentations and preferred presentation, prevention and reversal of diabetic kidney disease in general. I recommend all of you to hear this and listen to this video. What is this? Although it is not for diabetes management, but this is, I find it within the updated article this month. If you look here, this is CT scan with three-dimensional issues, and we have red color and the blue color. Red color reflects visceral fat, and the blue color reflects subcutaneous fat. And the software can present the visceral adipose tissue VAT to SAT, subcutaneous adipose tissue ratio. The higher the ratio in this article was not only associated with metabolic profile problems, but was affecting transplantation outcome. So renal function, the graft renal function, was significantly lower in patients with high VAT to SAT. So I put this slide here to raise the attention toward obesity. I don't like obesity, and we should combat obesity before and after transplantation. And we can say that if we want to successfully treat post-transplant diabetes, or to treat diabetes in general, we should follow a multifactorial and holistic approach. Holistic to treat everything. Treatment of diabetes is not restricted only toward hyperglycemia. Yes, treating hyperglycemia is crucial, and we should select anti-diabetic drugs according to the renal function, considering drug-drug interactions and the patient characteristics. One of the reasons to select specific groups like GLP-1 receptor agonist and sodium glucose cotransporter 2 inhibitor if you are dealing with obese patients, because GLP-1 receptor agonists and sodium glucose cotransporter 2 inhibitors are associated with reduction of body weight. So the most important patients that who will take the benefit, overweight and obese patients, especially if the kidney function is accepted and is we can give these drugs with the norm, because we need estimated GFR to above 45 to use sodium glucose cotransporter 2 inhibitors, and above 6 to use dapagliflozin. And here also we need kidney functions. So this is the important point. So for every drug here, sulfonylurea to be avoided in overweight because it will increase the risk of body weight. TZDs to be avoided in overweight because this class of drug is associated with edema. The insulin early post-transplantation period, kidney transplant recipient with severely impaired insulin secretion and or reduced renal function. So it seemed that this is the place of insulin. For DPP-4 inhibitors, kidney transplant with reduced renal function because we can use these drugs for all cases respective to kidney function following the modifications for each one, and one of them is not modified with any kidney function. So this is the rationale of selecting anti-diabetic drug. The second point, as I mentioned, treating diabetes should be holistic. So we should treat everything, hypertension and dyslipidemia, to treat hypercholesterolemia, because these are these are two important factors in cardiovascular diseases, and cardiovascular disease is the most important risk factor for mortality after transplantation. Immune suppressive drugs, we can switch from calcium inhibitors or methylation inhibitor to abatacept, or switching from FK to cyclosporin, or reducing steroid, or using immune suppressant regimens shown to provide the best outcome for patients and graft survival. So the wisdom is use immune suppressive drug in a wise manner. We shouldn't be overdoing. We should avoid unnecessary medications, unnecessary doses, and unnecessary levels, but we should put in mind the risk of rejection, because if we use inappropriate immune suppressive choice, this will be associated with increasing rejection that will be associated with increasing risk of diabetes. So we should use adequate immune suppression. Lifestyle modification is of paramount. Modifications are of paramount importance, including dietary, low calorie diet, physical activity, behavioral therapy, and to target weight loss in obese and overweight patients. So this is the map of management of diabetes at a glance. Is diabetes means holistic and treating the patients overall. We should target early management, addressing the screening, lifestyle intervention all through the period, from the early beginning, from the waiting list up to the end, beta cell protection after at the time of transplantation later on, monitoring lifestyle modification and early therapy to protect our patients. And I'd like to end with this quotation that we are living through learning, and this is what we achieved in the virtual academy, a lot of lectures and videos, and I'm so happy by the letter I received from Dr. Saud from Eritrea, who is appreciating all efforts we have done through the Egyptian Society of Nephrology Virtual Academy, and this is the most recent letter we received from him. He is speaking about that we should keep on and go on to keep it up, to keep all education up, and this is our vision and mission. And thank you very much for your attention. Thank you and goodbye.